Good evening, everyone. Thank you so much for coming out tonight. It's great to see such a good turnout. My name is Lisa Gray. I'm the president of A Promise to Jordan. And SCTV is filming us tonight to put the presentation on their station, but she's only going to be filming the presentation, no one in the audience, so no concerns about that. Again, thank you very much for coming out. This is a very important topic that we're discussing tonight, and it's great to see so many of you here. We do have a little bit of business we want to take care of with the group before I introduce our speaker. I'll just run through it. It'll just take 10 or 12 minutes or so. First of all, 1 year ago this month is when A Promise to Jordan started. So happy birthday to us. I started the organization, as many of you know, after the passing of my 24-year-old son, Jordan, whose pictures are up over here. I invite you to go and take a look at them before you go this evening. He passed away from a heroin and fentanyl overdose on June 30th, 2018, after struggling for almost 9 years with addiction. So he wanted very, very badly to help others in his situation, and he wasn't able to. So A Promise to Jordan is my promise to him to continue the fight to help other families and other people struggling with addiction, and hopefully make some change in this horrible epidemic that has really taken over the country. We have a few new things happening with our group. First of all, we have these great new tank tops and t-shirts that were designed. The logo was designed by Sandy Osella, who's sitting here in the front row. My husband is wearing the t-shirt as he's walking in right now. Model the t-shirt was here. With my Promise to Jordan on the back. It is a fundraiser for our group. Tonight only, the tank tops are just $10. The t-shirts are $12. I've got size small through extra large over here on the table. If you'd like to visit and purchase any before the evening is out, that would be wonderful. We want to spread them around as much as possible so people can see them. And the saying on it is really something that struck me when I first heard it. Love yourself enough to struggle. I feel like so many people who are battling addiction, they start because they don't have the strength to deal with some of the things that life has handed them along their road of life. Whether it be they've lost someone important in their life, or their boyfriend or girlfriend breaks up with them. As a young person, sometimes these things hit them really hard. If it's an older person, they've lost a job. There's all kinds of things that happen through our course of life. And some of us are able to deal with them and learn from them and move on and grow. But unfortunately, some of us turn to other means to deal with them, such as drugs and alcohol, and self-medicate ourselves. And I want to get this message out into the world that it's the struggles that make us stronger people. It's going through the struggles where we realize what we have within us and who we really are and how we grow as human beings. So love yourself enough to struggle. Get through it. You'll become a better person on the other side. So that's what it means to me. We also just recently we have our Facebook page. Many of you learned about the event through Facebook. We've got a donation button that we just put on our Facebook page within the last week. So we invite you, if this is a cause that's close to your heart, please think about going on there and making a donation. We also held a very successful fundraiser just down the street at Iron Horse Pizzeria and Sports Pub on June 6th, where we were able to raise about $1,700. So for those of you who came out and supported us that evening, thank you very, very much for that. Very much appreciated. We've had lots of press releases and articles in the paper lately. Maybe some of you are here because of those. It's been spreading a lot of information about our group and about addiction, and I'm very grateful for those. We also have a new website, apromisetojordan.org. I invite you to log on or go on to the website and see some of the information that we've got there. It's beautiful. It was designed by one of our members, Valerie Ives. She did a fantastic job on that for us. So please do visit when you get a chance. I've been fortunate enough to do a couple of speaking engagements recently. The last one was before the Freemasons. They were a wonderful group of men who have promised us a bequest at the end of the year as they get into the end of their fiscal year. And I'm also going to be speaking before the Simsbury Granby Rotary on next week, July 18th, 1 week from today, at Acupuncture Club at 7:30. Some of the things we have coming up, we've got a Narcan training scheduled for Simsbury. It's going to be September 26th. I don't have the location or the exact time yet, but it will definitely be on September 26th, so if that's something that interests you. I'm assuming everyone is familiar with what Narcan is, but if not, it is the generic name for naloxone, and it is the addiction, it's the overdose combating drug. If someone has overdosed on an opioid and is administered Narcan in time, it helps them to recover quickly from it and hopefully with no adverse effects. It is saving many, many lives. It saved my son's life 13 times before he finally did overdose the 14th time. And unfortunately, no one was there when Narcan to save him. So I think because the overdose problem is so huge, so prevalent, and going on all over the country and in towns like Simsbury, you never know when you might be in a place and have an occasion where someone needs to be revived with Narcan. So I think as many of us that can get trained and carry the Narcan, the better. The training will be free to you. You will go home with a free Narcan kit at the end of that day. I am also working on something that is very close to my heart. I would like to see Simsbury established as only the third community in the state of Connecticut to be designated by the state of Connecticut as recovery friendly. This is a new designation that the state is encouraging towns and cities to take on this year. The only other two towns that I'm aware of right now, maybe Judith, if you know of any others, please correct me, Danbury and Bristol. So Simsbury would just be the third one. And some of the examples of being recovery friendly would mean that our town is holding recovery friendly events and education programs, that addiction education and peer groups are offered in the schools, which is of course very, very important, and that businesses are open to hiring people who are in recovery. So this is something that our group is going to be starting to work on in the coming weeks that is going to be very important for me, I think. Also, we are in need of new board members. We have a board of 6 right now. One of our board members is walking right now. Hi, Val. We had a board of 7. Unfortunately, one person had to resign because of personal issues, but I would actually like to have a board of 11 if any of you have some time. It actually doesn't take a lot of time, but if you'd like to help us out, we are always looking for new board members, so please think about joining us. Our next board meeting will be Tuesday, August 13th. And we meet at USS Chowder Pot 4 in Hartford, so it's always a good dinner we get to enjoy there. And that's because some of our board members live in the southern part of the state, so we try to kind of meet halfway between here and there to make it easy for everybody. Our next group meeting will be Tuesday, August 20th, again at 6 p.m. This time it'll be at the Simsbury Public Library. And we're going to have a presentation on a program called CRAFT. It stands for Community Reinforcement and Family Training, which is a coaching methodology which is used throughout the state of Massachusetts. It's used quite a bit there. That families can use when relating to at-risk youth or someone with addiction issues who is resistant to treatment. It's a way that the families and the community can help to get them into treatment and overcome some of the roadblocks that are keeping them from getting the help that they need. So it's going to be a very important and informative meeting. I hope you'll think about joining us on August 20th at 6 o'clock at the library. Now, it gives me great pleasure to introduce our speaker this evening, Judith Stonger. As Vice President of Prevention, Wellness, and Recovery at Wheeler Clinic, Judith Stonger directs a number of programs, including the statewide Connecticut Clearinghouse Library Resource Center, the Connecticut Healthy Campus Initiative, the Tobacco Merchant Education Program, the Wheeler EAP, and numerous statewide training initiatives. Judith holds an MA in psychology and is a certified prevention specialist and appointed member of the statewide Alcohol and Drug Policy Council, charged by the governor to address the Connecticut opioid problem. She is a trainer in mental health first aid, applied suicide intervention skills training, mindfulness, and laughter yoga. Please join me in welcoming Judith Stonger.
So thank you, Lisa. Welcome, everyone, and congratulations for being here tonight, for opening up the town to the conversation about substance use and mental health. It's so important that we have sessions like this where people come together to reduce stigma, to make it okay to talk about substance use and mental health. And congratulations for all that you're doing. I mean, you guys are really a model town in terms of becoming recovery friendly, having Narcan trainings, having educational events. I'm sure you have a drop box in town, is that right, for medications? Yes, so you guys are right on point with all the things that you're doing. So congratulations to all of you for coming and for being here tonight. Okay, so we are going to talk about mental health and substance use. And as I mentioned, I do a lot of training, or as Lisa mentioned, I appreciate that. And so one of the things that we know, and I'm sure that you're all aware, is that language is really, really important. And so how we speak about people, what we call them, what we do to help them is just really important. And the language that we use in particular. So you all should have a handout, or there's one available in the back, that talks about what's not so good in terms of addiction, what's pretty good, and then what we really love. And this information comes from that Alcohol and Drug Policy Council, the Recovery Committee, and it's really well informed by people in recovery. So how do people really want to be addressed? So, for instance, addiction is a moral issue, right? No longer is that a belief, but addiction is a disease, that's good. Addiction's a health condition, just like anything else, right? Why do we treat mental health and substance use disorders so differently from a knee problem, a pancreas problem, an ear problem? Why are they treated so differently? And I'm not the first to say this, but just think about maybe a family member, a friend, someone who has maybe a heart condition, right? And so might people in the community come by or send a card or bring a casserole or call and see how they're doing? Yes? If my family member or my loved one has an addiction issue, or maybe has bipolar disorder or schizophrenia, are people generally coming by, sending a card, calling to see how you're doing, bringing a casserole? Usually not, right? So why do we treat disorders of the brain or the mind so differently, right? And that's a lot of what we do with mental health first aid training as well. We used to call people substance abusers. We don't call people who maybe have sugar problems or maybe have hypertension, we don't call them sugar abusers or diabetic sugar abusers, or people with high blood pressure, we don't call them self-abusers, right? We don't blame people for their disorder. So substance use disorder is better, addiction is the preferred. We used to call people addicts and junkies. What kinds of things do we say about people with mental health challenges? You don't have to be politically correct. What do we used to call them? Crazy? Nuts? Senile? Insane? Maybe retarded. We would sometimes laugh. We might define them by their disorder and say that's schizophrenic or that bipolar. We don't do that with any other medical condition, right? So sometimes we might even have things that people laugh at, like we say, oh, the elevator doesn't go all the way to the top, or there are a few sandwiches short of a picnic or something. Why are those funny, So having discussions like this is so important. A person is addicted, or a person is living with an addiction, and it's not defining them, but it's part of who they are. They have lots of other strengths, they have lots of other gifts, lots of other things about them, one of which is their addiction or their mental health problems. So I think if you look at this, you'll see again, this one in particular, it's been interesting, having been in the field for a while. We used to call people clients or consumers, which reminds me of Best Buy, that they're out buying TVs or something. And then we went to patients, and then we said people in recovery, and now we're calling them recoverees. But what do people you think really want to be called? Just a person, right? Why do they have to have that label with them, right? So they're just a person. All right, so we'll be careful about the language as we move forward. So we know that mental health and addiction affects people from all walks of life, all kinds of people, all groups. If you were to think about broadly the top 3 in terms of prevalence, mental health conditions, what do you think the top 3 might be? Question, someone say?
Anxiety.
Anxiety is far and away number 1. Okay, so somewhere between 18 and 20% of the population, and that's probably low, right, qualifies as having an anxiety disorder of some sort, okay? What's really interesting about that too is that if we look at the age at which they have the onset or the beginning of their anxiety disorder, and we look at the median, that's not the average, but it's if we lined everybody up according to at what point in their life they began their anxiety disorder, what do you think the median right in the middle would be? What age? What age would be the median age of onset of an anxiety disorder?
15.
11. 11, okay? There's a community I was working with, and there was a coalition similar to this. When they heard that, they said, we've got to do something about this. We have to do something to help young people, right, to manage their stress, to learn strategies for relaxation. So the median age of onset is 11 years old for anxiety disorders. Okay, so we need to just think about that. Anxiety is number one. What do you think is number two? Substance use and depression are sort of neck and neck. Okay, so substance use and depression, about 7 to 8%. This comes from a national household study. And so people had to be home. They had to have a phone. They had to speak English. So do you think it's, and they had to self-report that they had a mental health or substance use disorder. So do you think it's too low? Yeah, for lots of reasons it's too low. Okay, so what we're talking about tonight is co-occurring disorders, meaning a person who would have possibly both a substance use disorder or an addiction and a mental health disorder. So many people who have an addiction also have a mental health disorder, just as many people who have a mental health disorder also have an addiction. Is that news to anybody? No, you knew that, right? Okay. So the data from NIDA says that about half of the people who experience a mental health challenge will have an addiction at some point in their life. Okay? It does not mean that you have to have, if you have a mental health challenge, that you definitely will go on to develop an addiction. But we're going to talk about some of the reasons why they do co-occur in a minute. So about half of the people might have both. So although addiction commonly occurs with mental illness, this does not mean that one caused the other. Okay? So it doesn't mean that we can say that one caused the other, even if one was first. They're co-occurring, but we can't necessarily say that one is the cause. And establishing which one came first can sometimes be hard. So it can be a little bit of the chicken and the egg. And Lisa mentioned self-medication. We're going to talk about that a little bit as we move forward. So am I a person who has an underlying mental health challenge, and as a result, maybe I'm self-medicating, or for other reasons I start to use substances, and therefore I develop a substance use disorder? Or do I have an underlying substance use disorder, and because of using and the things that go along with using substances, I'm depressed or anxious, right? So you can see where it would be somewhat difficult to know which one came first, the chicken or the egg. Okay, so we know that some of the most common disorders found in people who have substance use are the mood disorders, so depression and anxiety. Okay, those are by far the most common. And a really high percentage of people who have schizophrenia also smoke and have substance use issues. Do you think that schizophrenia is common or prevalent? How many think it's prevalent? Okay. Yeah, a lot of people think that. It's not in the top 3, we know that, right? Right. It's less than 1% of the population, so it's not prevalent. But we do know that people who have schizophrenia in particular smoke cigarettes at rates of 70 to 90%. That's alarming, isn't it? Yeah. The general population is 20% or lower. It's dropping all the time. But for people with schizophrenia, they smoke at rates of 70 to 90%. Have you seen that? Do you have any experience with that? Yeah. Okay. And they're much more likely than those who have a mood disorder, anxiety disorder, to have also a co-occurring substance use issue. So sometimes we call it co-occurring, sometimes we call it dual diagnosis, a little bit older term. Sometimes we say that the two are comorbid, happening at the same time. But we know that, for instance, this is the group here who would have that co-occurring or that dual diagnosis. It's a combination of the two. When we look at the data, this is from 2017, and in 2017 there were approximately 325 million people in the US. And if you can't see this, hopefully you can see it on your handout. So just looking at how many people had a substance use disorder in 2017, it was a little less than 19 million had a substance use disorder. Close to 47 million had a mental health challenge. And then the intersection here is 8.5 million in 2017. Now it's up to about 9 million people. And again, do you think it's too low? For lots of reasons, all this data is too low, right? We also say that women have higher rates of mood disorders, depression, anxiety than men. And again, that might be a couple things. Maybe men are not recognizing it, they're maybe a little bit less reluctant to report. Sometimes depression, say, in men looks different than it does in women. So it might look more like something outward. It might look a little bit like irritability or aggression or anger. But for women, it's more that traditional turning in and looking blue and down and what we typically think of as depression. So right now we know in the US there are about 9 million people in that category of co-occurring disorders. So this is kind of the meat and potatoes here. When I was doing research on why we think that they sometimes or frequently will co-occur. And the first is that there are common risk factors. So risk factors, again, are things that might be attributes or things happening in a person's life that might make it more likely for them to develop either a mental health or a substance use disorder. It doesn't mean that they definitely will, but the more risk factors a person has, possibly the more likely they would be. On the other side, there are protective factors. The second one is that mental health disorders can contribute towards substance use. We're going to talk about that a little bit. And then substance use, in a way that you may not have heard before, can contribute to the development of a mental health challenge as well. Okay, so those are kind of the three that we're going to talk about. Common risk factors, mental health disorders contributing toward substance use, and some of the substance use contributing toward mental health. Okay, so some of the common risk factors, we know that there's a genetic predisposition for some of these disorders. So again, it doesn't mean that because I have a family history or I have genes that might lead me toward having a substance use or mental health challenge that I'm doomed to have it. By no means at all, okay? Addiction, mental health, definitely skips generations. Doesn't mean because I have a family member that I am going to, but it might be good information for me to know. It might be good to know that great-grandpa had an alcohol issue. Maybe that gene has been passed to me, and maybe I might be more likely, okay? Again, doesn't mean that I'm going to develop it. So genes can contribute, and are there common genes that contribute toward mental health issues and substance use issues? Genes can also influence how a person responds to a substance, how it makes me feel. Am I more likely to continue using that substance? We know that there are some groups of people who, for instance, are more likely to develop substance use disorders by virtue of their ethnicity. So, for instance, Native American populations have very high rates of substance use. So is there something in their genetic makeup or in their physiology that leads them to be more likely to develop a substance use disorder? More and more and more, we're talking about trauma, right? So, as you were mentioning earlier, Lisa, what are those events that have happened in a person's life, traumatic events, that may have caused distress, right? And we know that with those environmental factors, with that stress, people may be more likely to, say, develop anxiety or depression, or they might be more likely to use substances, right? There was an organization it's actually still around, but they don't use this name anymore, called Drugs Don't Work. And from the beginning, when I first heard it, I said, that's not true. Drugs do work, right? So if I'm a person who has had distressing events, I've had trauma, I've had a lot of stress in my life, maybe I'm very anxious or very depressed, and I use substances, and I get some relief from that, is that working? It really is, right? It's not what we hope people will do, but if I have a trauma history and I use substances and I get some relief, we shouldn't be surprised when people continue to do that, okay? So what kinds of things, what kinds of stressors might there be in people's lives? I know you mentioned a couple of them that might contribute toward either feeling depressed and anxious or feeling like I might want to use substances. What might those be? Violence, sexual assault. What else?
Economic.
Sure, yeah. Yeah, maybe living in poverty. Yeah, what else?
Physical illness.
Pressure to achieve.
Physical illness.
Physical illness, absolutely. Yeah.
Grieving.
Loss and grief, absolutely, absolutely. Maybe being bullying if I'm young. Maybe being part of a group like a LGBT community. Okay, so lots of things. These are stressful days, right? So more and more, we're asking people now when they come in for treatment, kind of like, what happened? You know, what's contributed toward your trauma? Fortunately, there's much, much more of a focus on trauma-informed care. So how can we treat people in a way that doesn't re-traumatize them, that recognizes that they do have trauma and treats them in a way that's helpful and doesn't re-traumatize them? So trauma-informed care is more and more, the expectation now. What about our waiting rooms? How do we treat people when they come in? What do they look like? What colors are there? So how can we help people and not make their trauma worse? Okay, so environmental factors. Can you think of any other environmental factors that might cause somebody to develop a substance use or mental health challenge?
Age.
Possibly, yeah.
I've just been
Disasters? Yeah. So you're seeing more substance use or mental?
Well, not the substance use, but the more depression and anxiety, so that can
Yes.
bring that on, possibly, not as much as younger people.
Yeah, and so that might be some of what we talked about earlier with losses. It's the number of people, I saw that with my dad, the number of people that he knew and his family and, neighbors who were dying.
They don't tend to run out and try to, because they're looking, but it's just
Yeah.
depression. And so,
Yeah. So maybe even some physical illnesses, as you were mentioning, some aches and pains, loss of ability, all of those,
Yeah,
right? Loss of ability, yeah. Can no longer drive, can't do the things that I used to want to do. All of these are contributing factors toward both substance use and mental health. Can you see that? Everybody? Okay. All right, so Lisa so eloquently talked about self-medication, right? So that some people with a mental health challenge will find that self-medication is sort of, whether they're doing it consciously or not, but something that they begin to do. Why is it ironic that sometimes people who have depression self-medicate with alcohol? What's ironic about that? Alcohol is ultimately a depressant, right? So in the long run, they're going to feel a lot worse. For a short time, they may feel a little bit better, but in the long run, they start to feel worse. Okay. So people who are anxious may need something to calm them down. We're going to have a slide in a minute. In particular, somebody who maybe is anxious in social situations. So think about, we work a lot with colleges. If I'm a college student and I want to go out and I want to be social, I want to meet people, I'm very anxious, what might I do before I go out? Have a drink or smoke a little weed? Yes, use something to calm me down, right? And if it works, will I do it again? Yeah, okay. So people who are depressed might want something to give them more life and more animation, help them to feel a little less depressed. People who are fearful may want something to relax them a bit and relieve that fear. And then sometimes people are in so much psychological pain that they just want to numb out for a little bit. Okay? They just want to have some relief from that psychological pain. Okay. And here's my example of social anxiety. And it's not just young people, it's in any kind of situation where people might feel like taking a drink or a drug will help with that anxiety and relieve it. So when doing self-medication, not only does it fail to repair the mental health condition that was the beginning, but it can also prevent a person from developing those effective coping strategies. Like I said, drugs do work, but it's not what we hope people to do. We really want them to develop positive, effective coping strategies. Okay, so if I'm using alcohol or drugs instead of learning those skills, then that's going to be a problem. If I am, again, using alcohol and drugs, it might interfere with my having satisfying relationships. I mean, I might have people that I use with, but maybe I'm not progressing in terms of relationships and moving on with my life and getting married and all that, but I'm kind of, maybe with people whose lifestyle is more similar to ours, and people may not feel comfortable with themselves as well. This is true of older adults and others, that alcohol can interfere with the medications that they're using for mental health conditions, right? Yes?
I was also going to say it also interferes with your normal neurotransmitters, so that
Yes.
it lowers your baseline.
We're going to talk about that in a minute. That's great. Yeah, that's exactly it. Thank you. Yep. Okay, so it can interfere in those ways as well. The third step, the third reason that they co-occur, substance use can contribute to the development of mental health disorder by actually changing the brain. And this is somewhat new to everybody except my friend here in the front row who just mentioned it. But it can actually change the way the brain works. We can call it a broken brain. We can call it chasing the high in some ways. And what I mean by this is that you've heard of dopamine. It's a neurotransmitter. And it's that neurotransmitter that helps us to feel good, allows us to get up in the morning and get going. And most of us are, let's say, at a baseline of about 100. It's sort of a normal baseline of dopamine. Some of us who might be a little bit, sort of sunshiny and cheery all the time, we might have a 105 or a 110 for our baseline of dopamine. And somebody who maybe is a little bit more down, maybe like Eeyore a little bit, maybe they have a 90 or 95. But somewhere around that 100 for the baseline of how much dopamine we have in our brain. Okay, so let's say that the baseline is going to be 100 here. What we know is that if you have great food, your dopamine level can rise to 150. So if we go to the chowder pot for the meeting that you were mentioning earlier, Lisa, and it's really good food, our dopamine level comes up. Is anybody surprised by that? Have some good chocolate, right? The dopamine level goes up. When we're done, over time it goes back to the baseline. Does that make sense to everybody? Okay. If we have an experience of intimacy, let's say, the dopamine level can go up to 200. Okay? After some number of minutes, our dopamine level goes back to the base of 100. Does that make sense? Let's look at some of the drugs. Cocaine spikes dopamine to 350, from 100 to 350. That's pretty high, right? Opioids, prescription opioids, 500, 5 times the normal level. It's pretty high, right? Heroin, 900. Okay, huge spike in dopamine. Methamphetamine, 1,300. Our brains, when they experience that, have this, wow, that is fantastic. Whoa, this is great. Feel fantastic. Let's do that again. Right? Remember what we talked about earlier? You're going to do it again. Okay? Let's do that again. At the same time, our brains are saying, whoa, this is a lot of dopamine, and we've never experienced this level before. It feels like too much. Okay, you're getting it so far? So I got this, wow, this is fantastic. Whoa, yes, amazing, so much better than food and sex. Whoa.
Psychologically, you feel that way, but physically.
Your whole body is feeling like, wow, this is great. This is great. My brain, my body, everything, I feel great. This is wonderful, like your best day. Whoa, do it again. Let's do this again as often as we can. But meanwhile, the brain is also saying, this feels like a dangerous level of dopamine. Okay? So what the brain is doing is saying, we got to shut this down in some ways. Even though it feels good, this is too much. So what the brain does is it starts to reduce the number of dopamine receptors that can accept this dopamine. It says, don't put out that much dopamine anymore when this happens, right? And it also, there's some suckers in there that say, like little vacuum cleaners, take out, it's too much dopamine. You follow me so far? Okay. What happens over time is that you can never get to this level again. Because of what's happening in the brain, your baseline is no longer 100. Your baseline, each time you use, is going down and down and down. Over time, a person's baseline may be 50 or 40 or less. Do you see? They're chasing what they initially were able to get from that drug. Their brain has changed. Fewer dopamine receptors. I'm sorry, I don't mean to upset you.
It's not upsetting. I'm just like the light is finally gone off.
I know, it is with me too. This is the work of Dr. Ruth Potee, P-O-T-E-E. She's given us her slides and lets us talk about this, but this is largely, she's from Western Mass. I would really suggest that you have her come down here and talk to you. It's really just important, right? So over time, fewer dopamine receptors. The body's saying, don't send so much dopamine out. Even though that felt good, it's just too much. And those vacuum cleaners to say, take some of this dopamine back, it's too much. The brain is actually changing, right? If I'm a person whose dopamine level is 50 or 40, I'm having a hard time functioning. I'm having a hard time getting up in the morning. I'm having a hard time, getting myself to a job or to school. I just don't have enough dopamine in my body. Do you see? Okay. So a person will be depressed, a person will be down, a person will be anxious. Does that make sense to you all? It's just really, really important.
So it's a protection for your body.
It is, yeah. It's your body saying, well, this is fantastic, we want more of it. It seems dangerous. It's just so much dopamine. It's too much. I can handle down here maybe around, 100 to 200-ish. That's about what I can handle. But when I get 900 or I get 1,000 or 1,300, I've got to do something. I've got to change the brain, and just turn that dopamine down. Does that make sense? So when we talk about chasing the high, that high is no longer achievable. And when we talk about people who over time, can't sort of mobilize themselves, that's why. Okay? One of the big reasons why. The brain is very plastic, neuroplastic. So really, Dr. Potee would be able to give you the definitive answer, but we know that people can heal over time and they can get more dopamine. Whether they'll ever go up to the 100 level or not, I wouldn't be able to say. I'm hoping that that's the case. We know the brain is really plastic and can repair itself. So I'm hoping that it's possible. Okay. The next slide is sort of the same thing, and this is showing, if here's our baseline, and this is an example of intimacy, so maybe we spike up, we return to the same baseline, okay? Here's someone who is addicted, and they have a high way up here, and then they no longer are returning to the baseline, they're going down there. Does that make sense? Yes?
I'm sorry if I missed this, but
Yeah.
Does that mean someone after their first high is also going to get a lower hit from sex and food? They'll have less dopamine receptors, I assume.
Well, that's a really good point. That's a really, really good point. I would venture a guess that that's true, but I wouldn't be able to say for sure on that. It doesn't make sense that there would be less pleasure. Do you know the answer?
Well, the baseline won't go down immediately, but
Yeah.
the contrast goes down.
Yeah.
so that you do get less of a high anyway.
Yes, yeah. So whether it affects other things like food and sex, I would think if you have less dopamine, it would make sense that it would. Yeah, you have to.
Comparatively, it will.
Yeah, yeah,
It will. That's
right.
My
yeah,
own experience.
yeah,
It does affect it because the high is not the high end.
yes. The high is not the high. Yeah, yeah.
It's not the same.
Right, yeah. It's important information. The first time I heard of this, I said, this explains what I've been wondering about for years. This really explains it for me, you know, in pretty simple terms. Okay, so this is actually looking at, these are control sort of brain images. And where you see the red and the orange and the yellow, these are dopamine receptors. So these are people who are not using substances. And then you can see over time, especially the heroin, the cocaine, you don't see any red anymore. That means that there are fewer dopamine receptors. So brain studies have verified this too, that there are fewer dopamine receptors to, you know, sort of engage with that dopamine. Okay? And meth, obviously, too, and alcohol. Questions? Yes.
So you might be getting to this, I
Yeah.
apologize. So we always hear about persons that use needing more, especially like you're just saying, because of the way your brain and your body's reacting. So you need more to feel that way or even better. But then I'm jumping ahead, looking at all of the other possibilities, if you will. So then you start mixing, because not knowing that you're mixing, not buying something, not knowing what's in there, but using more than one thing.
Yeah.
And then I'm thinking that so if the crash is even lower and the depression is even lower, then that's just starting a whole other vicious cycle.
Right. So now you need something to pick you up, right? Is that what you're going to say?
So that's why you can't really get out of the hole. Okay. I mean, that's
Yeah.
clear, but
Yeah.
I have to like...
Yeah, yeah.
Okay.
Yes.
I heard you have alcohol on this slide.
Yes.
It wasn't on the one before it. Is it because you don't get that kind of dopamine high, or is it the same?
I don't have the data on the dopamine rush from alcohol. Does anybody know that? No? I can look it up and let Lisa know, but it's a really good question. Yeah, it didn't appear on the other, but it is on this one, so it's a good question. Yeah,
Anxiety and panic.
Yeah.
Doesn't take the other drugs.
yeah, yeah. What we don't even have on the slide is yeah,
But it does affect her dopamine receptors, according to this, right?
it does. Yeah, not as much. I don't know if you can see it or not, but there are reds here.
Okay.
So it's not nearly as much. And that might be why alcohol wasn't included on the others, because those were the really, really big examples. Methamphetamine is the biggest, so it was the dramatic examples that were on the other one. Yes.
This might sound ridiculous question, but where are the dopamine receptors in what one of the quadrants or parts of our
Yeah, they're in the reward system, right? So the reward system, yeah.
Low.
The reward system is a very primitive part of the brain that basically says from, you know, ancient times, we need to get up, we need to get food and water, and we need to procreate to continue our species. Right?
Yeah, I guess I'm asking
Okay.
right lobe, left lobe,
It's,
frontal right.
it's in the center. It's right here, the reward system inside.
in
Yeah.
each right and left lobe.
Yeah, it's inside, yeah, okay. And what happens is it hijacks that system. So no longer am I looking for procreation, food, and water. It starts to hijack, and basically what's happened with that was amazing, let's forget those other things, let's just go for the drug. So it hijacks that reward system in the brain. Does that make sense to you?
It does, but I don't know if it actually answers what I'm looking to have answered. While
Yeah, it's inside, in the center of the brain, about right here. So it's not on the left or the right, it's inside here.
Way in the center.
In the center, yeah. Okay? Does that make sense? Okay. All right. So important information. I would really recommend Dr. Poti come down. She speaks a lot in Connecticut. And she's a medical doctor. She's got tremendous experience, speaks all over, has done a lot of research, and is really great about answering questions. Okay. All right, so the 3 reasons: common risk factors, mental health disorders can contribute toward substance use disorders can change the brain and contribute toward mental health challenges. Those are the 3 reasons that we discussed tonight, okay? So when it comes to screening, in the not too long ago past, when people came into an agency, an organization, they went into one door for their mental health disorder, for their depression, anxiety, and there were people there who knew how to treat that and screen for that. And then they went into another program, another area, another building for their substance use disorder. It's the same person, right? So now recognizing that the same person has, co-occurring disorders, we now need to train and screen and identify people no matter what door they come in, okay? More and more we see that agencies are not only trauma-informed, but they're doing integrated care. Integrated care. Why we weren't doing it before, I don't know. So one person comes in and we treat them holistically. So they have a mental health challenge, we help them with that. At the same time, we help them with their substance use disorder. At the same time, we help them with their hypertension, their diabetes, and their dental care, right? And how about using some of those complementary strategies in addition to medication? So maybe we do some mindfulness and some yoga and some chiropractic and acupuncture with them. Doesn't that sound a lot better? Many agencies like Wheeler and others also have now open access, meaning that no longer do I call, I'm ready for treatment, this is my day, and we're told, okay, you have an appointment in 3 weeks. Open access means I can walk in and I can be seen. Okay, so lots of really important changes in the way we treat people. So we look at them holistically. No longer do we, treat their mental health separately from their substance use, and no longer do we not even know that they have, a physical ailment that might be contributing toward all of this, or they might be taking medications that are, contributing toward their depression, anxiety. So now looking at the whole person in a holistic way.
When was that changed?
It's changed in the past 10 years or so. Most agencies are going that way.
So when you say open, more, are you referring
Open access.
more to, say, if I walked into Wheeler Clinic and I needed assistance versus walking into a detox and getting a bed? Those are 2 very different avenues?
I'm afraid they probably are, yes, yeah. I'm talking about,
that's changed.
yeah, no, I'm thinking about outpatient, yeah,
Okay.
outpatient services for the most part, yeah.
Thank you.
Yeah, yep. Okay, so we need to have comprehensive tools, we need to have effective tools to reduce the chance of either missing that a person has a mental health challenge or a substance use disorder. And again, no wrong door. However you come into our organization, we're going to look at you holistically. Think about dental, right? So a person has a mental health disorder or a substance use disorder, they got some help with that, their teeth are not in good repair. So they have other kinds of issues. Maybe they can't go for a job interview, or they're having trouble, with relationships or something, or self-esteem because of that. So looking at the person very holistically, no wrong door. So the diagnosis can be complex. It's often sort of an art to untangle. Is this substance use? Is this mental health? Is it both? Is this medication related? And so most effective treatment, as I mentioned, is treat them together. Okay, so at the same time, treat the mental health challenge and the substance use challenge, rather than doing them separately. Here's some websites that could be helpful to you. This is the statewide website that was developed as a result of the opioid crisis through the Alcohol and Drug Policy Council. Live Loud is a campaign for those who have a substance use disorder who are looking for help and treatment. This is the Department of Mental Health and Addiction Services. 211. You can call them for just about anything. NAMI, you have a NAMI group here? Good. Connecticut Clearinghouse is one of my programs. It's a library and resource center in Plainville. We have books, videos, curricula, we have pamphlets, posters, fact sheets. It's all free, and we're happy to provide you with those materials around the subjects of mental health, substance use, and lots of other issues related to those. Okay. And does everybody know this number now, the statewide number for accessing treatment? Are you familiar with that? It's a number that people can call for treatment. Transportation can be provided. Help with detox. It's a program of DEMIS. It's actually answered at Wheeler. So please have that number with you. We have lots of resources from a campaign called Change the Script as well. And that's about really educating people about the opioid crisis, about the need for naloxone, about safe storage of medications, talking with your doctor about alternatives, lots of things. And there's a little card that has that 800 number on that I like to carry around. And if I see someone, I say, I hope that you'll use this someday, and they're very grateful to get that. So we have lots of resources. We have posters, lots of things that you could, avail yourself of. We'd be happy to have you do that.
Can anyone call that number for addiction treatment? It doesn't have to be the
Anyone.
addiction, the addict itself.
Call. Just call them. Yeah. Okay. Stamping out stigma, I think you all are doing a great job with that. We'd like to call it discrimination. It's more than stigma. People who have mental health and substance use disorders can be discriminated against. Yes?
I was thinking, when, you're talking about all these great resources, and it's fabulous, really wonderful, but, when somebody first comes across and realizes that their kid has a drug addiction problem,
Right.
You're so completely blindsided, and you feel so stupid because you're thinking, I'm living in the same house as this person's my child that I love, that I adore, that I nurture, that this, that, and the other thing, and all of a sudden you realize after probably, with my daughter, it was a few years, she's a drug addict. How the hell did this happen?
Sure.
So, and I didn't even know I didn't know where to start.
Right.
And I have to say, thank goodness right now she is 4 years and 7 months clean and sober, which I'm really proud of her for.
Fabulous,
Yes.
fabulous.
Thank you. She worked hard for that.
Yeah.
But my husband and I, we were both completely blindsided. I was frozen in place. He was able to kind of move and get it going, but we
Sure.
didn't even know where to start.
Sure.
So this kind of information, has to get out there.
Yes. So your story is very typical.
I know.
Nar-Anon as well. Do you have Nar-Anon meetings here? NA, AA, Al-Anon meetings? NA? Families Anonymous as well. Great. There's a program called Hidden in Plain Sight. I believe that's the name. Has anybody seen it before? They come in and they set up a replica or the representation of a teen's bedroom. And they say, I'm going to give you 15 to 20 minutes to find what might be drug paraphernalia or drugs here. So you go and you look and you say, there isn't any. There's nothing there. There's absolutely nothing. It's a typical bed. There's a few things. There's a backpack and maybe a purse and a pillow and some clothes on the bed. A little maybe nightstand. An umbrella's there, a can of soda. Okay? So she says, keep looking. You would never believe it. You would feel like you were from another planet, right? So you pick up the can and you unscrew the top and, right? You take the umbrella and you unscrew the bottom. So these are things that can be purchased on the internet. You take the t-shirt, and in the back, do you know how there's double seams on a t-shirt? It's been slit a little bit, and there's drugs in there, right? You would never in a million years believe all that's in there. There's a little tampon that has drugs in it, right?
That's what I mean.
That's what you mean, right? So it's very eye-opening for people. Your experience is very typical. It's another thing you might want to consider having in town. I mean, it's very impactful, and everybody just says, well, I guess there's nothing here. They must have forgotten to put them out. And then there's probably at least 20 examples and just this little setup of where drugs can be hidden. Yeah.
You know, things have improved a lot. When my daughter started by getting a prescription from a doctor. And I literally, she was a little older, she's out, but I literally go over and make sure she had her meds.
Right. Because a good mother does that, right? Right.
But, you know, I've learned a lot in the process, but I just can't believe I did that, you know.
Right.
So that's the whole idea of education.
Yes.
And taking away the stigma and,
Yes.
you know, and having
Yes.
people talk about things.
Having people talk, right. So you know there's laws now about how much of opioid prescriptions can be given, right? So how many of us maybe had a wisdom tooth out or something, or a tooth out, and we got 60 pills, right? And we needed maybe 1 or 2 or 3. Yeah, yeah.
My daughter had a C-section and got 30 pills.
Yeah. Yeah, and she didn't use them all, did she? Yeah. So then, you know, there needs to be education about making sure it's locked, disposed of properly. I know someone whose grandmother had passed, and she had quite a, you know, chronic condition and had lots of medication in a closet. And the woman said that during the weekend after the funeral, there were lots of family members and friends coming through. And by the end of the weekend, a lot of the medication was gone, right? I know someone he's in recovery now, but he was a carpet installer.
Interesting.
And he said he would go in, and he tells this publicly, he would go into people's house in the morning, and he'd say, excuse me, would it be all right if I use your bathroom? And they'd say yes, and then he'd go in and see what they had. And inevitably, they would have something that, you know, he could use, and then he would take that, and the next day go to someone else's house. So it's about education. We're working with realtors as well, the Connecticut Realtor Association, and really educating people about open houses. So it's not just your valuables, your jewelry and money and things that need to be locked up, but your medications.
You know, I'm working with a teacher, I work in high school, but he was sharing with me the other day, and this blew me away, because I thought, wow, nobody does that anymore. He said because the kids can't get the opioids as easily, they're doing cough medicine, big time.
Yeah,
And
that's,
he says, but they'll share with them, like bottles of it.
He's not joking, because
No,
I was
I
trying to
know.
run one of the events at the high school.
Yeah.
One of the post-grad parties. And afterwards, I was in the bathroom on the first floor, and I opened the garbage to throw away some paper towels from washing my hands, and there were like 5 cough medicine bottles in there. And
I mean, that was like the old school, and it's back again.
it is old school, yeah.
Anything, so it's like, we'll have to lock that up.
I was just going to say, is there a way in which we might be able to talk to CVS and Walgreens and local pharmacies about that?
And this was last year that he
Yeah.
told me about his class.
Yeah, so that's back again. Yeah. We're working with the Funeral Directors Association as well around a couple of things, education and materials for people whose loved one may have passed, especially from an overdose, but having naloxone on hand for the wakes and the funerals, and also giving the disposal bags, their disposal bags to the family members so that they have a means of disposing of medications as well. Yeah. Did somebody over here have a question?
No, you just blew me away with your comment before.
Which one was that?
About the carpet install.
Yeah, so just, be mindful that when people come in your house,
Well, my
your
nephew's
kids'
a
friends.
carpet installer and a recovering drug addict in Connecticut, and he did maybe the same individual, but he did the very same thing.
Okay,
Every house.
yeah,
Every house he went
Yeah.
into. And he works for a business that is owned by his father. And my brother could not continue to bring them into these homes and
Yeah.
these areas.
Yeah.
Everything was gone.
Think about dopamine down here. It's not a
He didn't
baseline.
care.
No, I'm just saying, if I'm going to be working all day, maybe I need a little something to try to get me up a little bit.
Steal it, run down the street,
Yeah.
steal it, come back.
Yeah.
It didn't
Yeah.
matter.
Yeah,
I had that happen with my medicine from my C-section from a paper bag.
yeah, yeah,
They asked to use the bathroom,
yeah,
they were in there, I never heard a flush, I was like, what in the world?
Yeah,
And then, you know, I had like a newborn infant, so we're going to think you good.
sure.
And there was one pill left in the bottle. It was like I wasn't going
Yeah.
to notice.
Yeah.
One was done. Right.
Yeah,
Yeah.
it's one in case.
Yeah.
But I mean, it really doesn't.
Yes, yeah. How much do those pills go for on the street?
They go $10 a milligram, so it's 80 milligrams.
$80, yeah. So 30, 50 to $80 for one pill. One pill, yeah. Yeah. And heroin is $5, could be even lower, $10, $3 a bag. So that's why people are switching over, yes.
What's your recommendation for people that are in denial, no matter if they sat through this course and 100 other courses and IOP programs and everything you could think of and still say, it's not a problem?
Is that the program that you were talking about, Lisa, that's coming from Massachusetts? She was asking about people who are in denial and who are just really reluctant to come to treatment. Is that the program that you were talking about bringing?
That might be a good option, that craft.
The craft? Yeah, it sounded like that's what you were talking about.
So many addicts don't want to recognize they have a problem. And we all recognize it, people
Right.
closest to them
Yeah.
recognize it, but they think they can handle it themselves.
Yeah.
They don't need any help.
Yeah,
It's very common.
yeah. So I'm hoping that you heard that, the craft.
This is a program that you need to go to Massachusetts, or is it online?
No, it's, Lisa's bringing it here. Yeah, it's coming here.
August 20th, we'll be having it.
Okay, yeah. Does anybody else have any suggestions for her? About people who are reluctant?
Well, some people try to do interventions where they get
Yeah.
the whole family together and talk to them. But usually it's a matter of consequences. People have to have consequences to their use. If they don't have severe enough consequences, they don't stop. So there has to be consequences.
Right, yeah,
I think what happens with that is that the consequences are hard because when you have the mental illness and you realize that it's so twined together, it's not like having just a little kid and saying,
Yeah.
"Okay, you can't play with the fire."
right. It's complicated, right? Have you ever seen the stages of change model?
No, I've seen it in real life.
Yeah. So I would recommend that you Google stages of change. And there are 5 stages of change. From pre-contemplation, not thinking that this is a problem at all, not even in the realm of my thoughts, there is no issue whatsoever. So if the person is pre-contemplative, for us to say, I think you need to go to treatment, it'd be like, me? They're not even thinking there's an issue, right? And maybe that's because they haven't really had those consequences yet. What we hope is that they move into contemplation, and that's when, you know, maybe I'm starting to hear from my parents, or maybe my spouse is thinking of leaving me, or I'm having troubles at work or other places, I've been in a, you know, got a DUI. Starting to think maybe there's something, a connection here, right? That's contemplation. But we don't want people to stay stuck there either, just thinking. The next step would be preparation. Okay, so what would it take for you to actually, you know, cut back or stop, or, you know, what do you think you might do? Might you go to treatment, or might you go to detox, or a 12-step program, or talk to somebody, go to counseling? You know, what do you think might help? Medication-assisted treatment is great. You know, so helping them to maybe even get into preparing. They're not actually doing it yet. Okay, and then they move into action. So this works with whatever you want to do. If it's quitting smoking, losing weight, whatever. So now I'm moving into action. Maybe I will make an appointment. Okay, maybe I will try to cut back. Maybe it's a harm reduction. Maybe it's not abstinence, but maybe I could cut back a little bit. Whatever that might be in preparation. Okay, and then we hope that they maintain that change. Okay, and we shouldn't be surprised if there is some relapse and then they start again. And that, so have you heard of that before? Has anybody heard of it? It's really fantastic in terms of how do we talk to people? If we know where they are in the stages of change, it's a whole lot easier to talk with them, okay? Like I said, if you're pre-contemplative and I give you an NA schedule, this must be for someone else, right? But if somebody is, say, in preparation, and we say, you know, I know of a program, or I know of a person, or I know of a strategy, or this helps somebody else, or, you know, would you like to speak to somebody? However, we try to move them maybe into action, because we know they're preparing. They're thinking, they're preparing. Does that make sense to you all? So when we do the mental health first aid training, which you might want to do at some point, it's 8 hours, but if anybody's interested, we do free trainings on mental health first aid. It talks about a lot of what we're doing here, but we do go through the stages of change and how important it is for us to recognize where people are, and then how we might be able to match what we say are our intervention with where they are, and to help them to move along in stages of change. Okay. One of the things we might do is to say to them, on a scale of 1 to 10, how likely are you to maybe cut back or to stop? Okay? On a scale of 1 to 10, how likely are you? And let's say they say 3. You say, that's fantastic. How come it's not a 1 or a 2? You always go down. How come it's not lower? They're going to tell you why they think they need to do that. It's not a 1 or a 2 because, I just got a DUI, I went to jail, I never want to do that. My mom's kicking me out of the house, I lost my job. Okay, all right, so what would it take for you maybe to go to a higher level, to a 4 or 5 or 6? Okay, does that make sense to you? Look up stages of change. It's a model that's been around for 50 years or so. It's tried and true. It helps us get to the gym, stop eating chocolate, dieting, whatever it is. We can look at ourselves. Where am I? I'm pre-contemplative. I'm contemplative. I'm preparing. I'm in action. I'm maintaining that. That's great. I had weight loss. I'm maintaining it. If I relapse, maybe I better come back to thinking about it again. Okay? Yes?
I also want to mention if you're dealing with somebody that's not willing to going yourself for your therapy or going to
Yes.
Narconon or Al-Anon or
Yeah.
what's it,
Family
Al-Anon,
That's what I was going to say.
Fantastic.
Family Anonymous,
Yeah.
Al-Anon, I've done Family
can be
Anonymous
very
for
helpful.
ever, because you can't change you can change yourself, you can't change
That's
anything.
Yeah.
And that's what the group tells you, it's the 12-step program, although it's for the addict's family.
Yes.
And they teach Al-Anon, and I go to Families Anonymous.
Nar-Anon, Al-Anon, Families Anonymous. There are also some opioid education and family support groups around now, too.
First step is you can't change anything.
There are support.
You can only change yourself. And so it helps you live. My son started taking opioids, but then discovered he was a type 1 diabetic. So he stopped taking opiates, but he smokes marijuana. So he has never been in recovery, and it helps you live with somebody that chooses maybe not to recover for whatever the reasons are. He's still living a good life, and I'm still living a good life. But
Fantastic.
To marijuana in this state as being legal, do you have any opinions?
We turn off the TV.
sorry about that.
I think it's a horrible idea. I think it's a horrible idea. When the perception of harm about a substance is low, the use goes way up, right? So when kids hear recreational, legal, decriminalized, whatever, they say, hey, this stuff is fine, let's do it. It's not okay. Dr. Pody will talk about the developing brain and what marijuana does to the developing brain. It changes the brain of young people. Until at least 25, we know it's still developing. It's not a good idea. The marijuana that's out now is extremely potent with THC, which is the active ingredient. The edibles are extremely, extremely high in THC. Data basically shows that, for the most part, people who are doing other kinds of drugs have also used either tobacco, alcohol, or marijuana, for the most part. They've used one of those.
And is there enough of a campaign or pressure on the state to not get into this? Or is there anything?
Do you know the faith community had a big impact this session? There were a number of faith leaders who went and spoke at the Legislative Office building, their opposition to it. So there are groups definitely who have coalitions. There's a local prevention council here in Simsbury. I'm sure you're familiar with them. and your regional behavioral health action organization, all of which are all working on the issue and trying to, the states that have legalized it have lots of issues as a result of it. If you've been to Seattle and have seen the homeless population, or Denver, and then they say things like the number of DUIs and drug-related accidents and things have gone skyrocketing. How could you be surprised by that? So I personally, I'm just speaking for myself, I don't think it's a good idea. And I will go so far as to say that shame on us if revenue is the reason. Shame on us if that's the reason, because that's very short-sighted too. Because of the damage that it will do to individuals, to families, to communities. I think it's very short-sighted. It's only my opinion. I'm not speaking for Wheeler or anybody else.
No, I wonder if they would even just not even deal with it if there's no money involved. If it's just another thing they're going to make legal, then, but no money. The state gets no money, but they feel differently about it.
Right.
That wasn't even be on the table.
And whether big tobacco is behind it too, big tobacco will come in and take up over all these little mom and pops, and it'll be, a big industry for them. So just look at the vaping. Don't even get started on vaping. I know it's a huge problem in every high school in the state. And some of them are vaping marijuana or hash oil. So, yeah.
Can I ask about your open access?
Yes.
And the integrative?
Yeah, sure.
So I'm reading a lot online and involved with a lot of people online. And so Wheeler is open access. But I'm hearing a lot of people having a very hard time finding somewhere to go or get it, kids that are at college that can't see a therapist for 3 weeks or a month or that kind of thing. So is there a way to find open access wherever you are? Is it just Wheeler? Is it?
I would hope that 211 would have that information.
Is that nationwide or is that only access?
Yes, yeah, open access means that you can just basically show up when you're ready and you'll be seen. Now, will there be a little bit of a wait possibly depending on how many people are ahead of you? It could be, but it doesn't mean that you're going to wait a week or two or, several days.
That's only at certain places, right?
Yeah.
It doesn't mean all
No, it doesn't.
clinics and-
No, it doesn't. I believe that's the direction that most are going. As you can imagine, it's very difficult to manage and to know how many intake clinicians do we need today, right? So you don't want people to be waiting too long. So we're working at Wheeler on streamlining that intake so that people don't have to wait as long. You need to get information, obviously, and you want to do a good intake, but just making sure that people are able to be seen in a reasonable amount of time. So I would suggest that you either call organizations that are nearby, look on the 211ct.org website. There's another website called Connecticut.networkofcare.org. Connecticut.networkofcare.org. And that's also, it's 211 information, but it's able to be accessed in a different way. So you're able to say that I'm looking for, addiction, detox, for teens, etc. You also know about the EMPS system for teens. Do you all know about that? Emergency Mobile Psychiatric Services. It's actually, that's what we commonly have called it. Now it's called Mobile Crisis Intervention Services. It's accessed through 211. It's a system that's funded by the Department of Children and Families, and there are providers around the state who are providing crisis response services, mobile crisis response services for kids that are in need or in crisis. So the young person up to age 18 can call themselves, I think 18 if they're still in school, can call themselves a parent, a teacher, administrator, a program person, a pastor, chaplain, can just call and say, we would really like somebody to come out and help us. And that mobile crisis team comes out. Okay? It's very successful. It's actually a model that has, I think it was USA World Report. It was just in this week. So it's being emulated around the state. All goes through 211, and if you call and 211 patches you through to whoever your provider is, they will come within 45 minutes. Yes. Yeah. Yeah.
My question But those things are all things to me, and they do have to make a choice. Does that mean that because of what happens in the brain, they're not able to make those choices?
I like to believe what you said at the end, right? That, as I was mentioning earlier, there's a reward center that gets hijacked by the substance in the case of substance use, right? That becomes the most important thing to me. Forget everything else, right? That's my goal now, to get drugs. And part of it may be that low dopamine, but I just need to get the drug again, right? Yeah, there's nothing that they won't do. Yeah. Do they feel badly about it? I'm sure. Who wants to steal from their parents? But I've got to have the drug. You know, it's not that I'm just thinking it would be a good idea. I have to have the drug, right? Like we need air. That's a good way of putting it. Yeah.
This is about the Wheeler Clinic or any other place you might know of. I'm familiar with the anonymous support groups and the multitude of them.
Yeah.
I'm wondering if there's any treatment programs where people that have actually been in recovery and had success with recovery can go and actually be like re-upped or helped with the problems, the long-term effects that they have, even though they've been able to be substance-free, like the long-term effects of the addiction.
Sure. Yeah.
Is
So
that some of what you're saying that Wheeler offers, like with the integrative medicine? And
sure. Yeah. I mean, just coming in and saying I'm a person in recovery. I'm still having some struggles or some things I'd like some help with, as any of us would, right? So exploring what might be helpful. Maybe it's cognitive behavioral therapy. Maybe it is some medication, a medication-assisted treatment of some sort. Maybe it's doing some of the more non-traditional complementary kinds of things. Maybe yoga would help me out, or walking or exercise or other kinds of things. Acupuncture. We're doing acupuncture detox now. It's been shown to be effective. So I think for anybody, all of us, right, at different points need help. So certainly a person who's in recovery to go in and say, you know what, I just need a little bit more support. Absolutely. Yeah. The other thing I wanted to mention, if you haven't heard about it too, and I thought this might be what you were asking initially, is about recovery coaching. So there's an organization called Connecticut Community for Addiction Recovery, and they support people. They're a recovery support organization. And so one of the things that they do is they train individuals who are in recovery to be recovery coaches. And so you can go to CCAR and ask to speak with a recovery coach. This is someone who's been successful in recovery. And they are very much into multiple pathways. What do you think will work with you? How can we help you? So we're not going to tell you have to go to 12-step. We're not going to tell you have to go to detox. But what would work for you in terms of your choice of methods of recovery? And one of the great things is that there's now funding for recovery coaches to be employed and at emergency departments, okay? If someone is in the emergency room and it's somehow related to their substance use, this is a perfect teachable moment to say, how do you think your substance use contributed toward your reason for being here today, And then would you like to speak to a recovery coach, And it's optional, but that recovery coach, can talk with you about options, and they've been extremely successful in connecting people with programs and opportunities for recovery, whatever that might be. So doesn't that make sense, right? Yes.
Does it ever get addressed at the level of when somebody gets a DUI and they end up going to jail for a period of time? Like, they don't necessarily have programs in the jail when you're in there for that
Right.
for recovery, right?
Yeah.
They're just
Some
they're
do.
basically locking them up.
Yeah.
And
Let's hope that that's going to be changing more and more over time.
do you think
Yeah.
they're starting to?
They have, like Hartford Correctional has AA meetings, they have peer group meetings, they also have some teaching. They have phase 1, phase 2. They do have some substance abuse education in prisons.
One of the things that we know, especially about opioids, is that when people are using, they develop tolerance, right? Meaning that they need more of the substance to get the same effect. And then when they go into jail or prison or into treatment, and they're not using for that period of time, their tolerance drops, right? Tolerance is back down here again. There's a huge number of individuals who are overdosing within, say, 30 days or so after coming out of jail or prison or out of a treatment center and deciding to use again. And so they're using where they thought they were before. When I went in, I was up here, and their tolerance has dropped and they're overdosing as a result of that. So the prisons now are doing more with connecting people and putting them on medication-assisted treatment and connecting them with resources in the community, pre-release, so that post-release they have, much more of a chance of getting through that period and maintaining their recovery and their sobriety. Does that make sense? Mm-hmm. So let's put them on medication-assisted treatment before they get out. Yeah. You know the dangers, too, of using opioids and benzodiazepines? Are you familiar with that? When a person overdoses, their system starts to shut down, including their respiratory system. Okay. When you take a benzodiazepine, those are for anxiety or for insomnia, those also slow down your respiratory system. So now you've got a double whammy, right? It's very important that people realize that if they are using opioids or using benzodiazepines, that they should never be mixed. Okay, there are a lot of people who are overdosing as a result of that. Fentanyl is obviously the big issue now. We all know that fentanyl is, in so many drugs now. Yeah, it's a manufactured, basically, opioid, okay? Very potent, 50 to 100 times more potent than heroin. It's usually made in China, so it's a manufactured opioid. It doesn't come from the opioid plant, but it's a chemical. It's a synthetic, is what I'm trying to say, yeah. And there are many analogs of it, so it's not just fentanyl now, it's carfentanil and other kinds of fentanyl that are, slight.
But is it used legitimately in the medical?
Yeah.
Okay.
Yeah, so if somebody has end-stage cancer and severe pain, they might have a fentanyl patch. They might be given fentanyl. So there are legitimate reasons for it, but when someone is not having that pain, that's when the problems begin, yeah. And so as a result of that, you were talking about Narcan and or naloxone. It will take more of that if fentanyl is involved because it's so much more potent than heroin. It will take more of the Narcan or naloxone, which is the antidote, to bring someone out of an overdose. You know what I mean? So yeah, so now first responders and people who have that antidote drug now need to have multiple doses, yeah. Another thing to know is if someone does come out that they may, within an hour, hour and a half, maybe 2 hours, they might go back into the overdose. So we need to not leave them alone. Yeah. Yeah. What happens is just like there are dopamine receptors, there are opioid receptors in the brain. And if this is one of them, the heroin or the fentanyl is attached here on the receptor. When Narcan or naloxone comes in, it quickly knocks that one out and puts right here. So people come out of the overdose, as you mentioned, really quickly. Yeah, yeah. So it's also very benign, so that if you do suspect that someone has used an opioid and has overdosed, and you give them naloxone or Narcan, especially the easiest one would be the spray, and they're not using that, it's not a problem at all. When the issue happened on the Green in New Haven, it was K2. But if you listen, they gave them Narcan because they didn't know if maybe it was opioids or maybe it was a combination. So they gave them. It's not going to harm them at all. No, there's Good Samaritan laws that say that you can't be liable for doing your best as a Good Samaritan and helping somebody out. Yeah.
Are the benzodiazepines you were talking about, are those addictive also?
They can be. Yeah, people can become dependent on them. Yeah.
It's not as dangerous as opioids or fentanyl?
Well, people are overdosing on them as well. Benzodiazepines. So it's for anxiety or insomnia. So Xanax, Valium, Ativan. Yeah. 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 Okay. So some of those, just be careful with them. And again, we're not against these medications by any stretch of the imagination, but we do feel it's important that you have a conversation with your doctor, that you understand the risks and the benefits, that there's a plan for, monitoring, for maybe trailing off. How long will I be on these? Is it safe?
Doctors should be saying something about them too, because
Yeah.
I know from experience,
Yeah.
because I'm hearing you, and years and years and years ago, I had an anxiety issue, and he put me on the generic form of Xanax, it's called Prevalent or something like that. And it was never even mentioned. that
Yeah.
it was an addic-
Yeah.
I did the research and realized it was
Right.
addictive and was scared to death of it. And
Right.
He
Yeah.
just said, well, just keep one in your pocket, even just knowing that you
Yeah,
have it.
sure.
But he never once
Right.
mentioned that I should be careful because this is
Right.
an addictive, never once mentioned.
Right. So might the pharmaceutical companies have been a little dishonest or less than forthcoming with some of this? We don't know. They're trying to sell things. They're trying to sell opioid drugs and benzodiazepines. So are they 100% upfront? Did they know how addictive they would? Maybe we don't know, but there, sort of we became this culture that everything was about taking a pill. One of the initiatives that we're looking at now is resetting pain expectations.
Yes.
Right? So I tore my meniscus in my knee. There was pain, and I was glad because if I had the pain, I knew don't do that, right? Pain has a function sometimes. So for us to think, as a society that we have to be 100% pain-free when maybe we just had surgery or maybe we were in a terrible car accident, there may be some pain, and maybe the pain is functional, and maybe we need to look at alternatives that, things that we used to do, like heat and ice and physical therapy and, some of the over-the-counter kinds of medications, some of the complementary kinds of things like acupuncture, cognitive behavioral therapy, and other things, yeah.
The insurance industry
Yeah.
needs to get, and I'm on Medicare, I have a
Yep.
backache. They'll give me all the opioids and whatever I want, but they won't cover acupuncture or.
Yeah.
I don't have clothes I pay for stuff like that.
Yeah, so, yeah, I know, I'm not
Yes.
taking any of that
Yeah.
stuff, but I'm going to
Yeah.
pay out of pocket for acupuncture.
Time's up? Yeah, okay.
All right, we can take one more question, and I think we're going to wrap it up as the hour is getting late. I'm sure Judith will stick around for a few minutes if there are any additional questions. Is there one more question anybody wants to ask Judith?
I'm so with you about the insurance company. Yeah, we do need to do some work on policies and legislative
They'll pay for my
changes.
addictions,
Yeah,
but they won't
yeah,
pay for alcohol.
yeah. Wellness, and other kinds of complementary things. Yeah, right. Yeah.
Well, thank you very, very much.
Thank you. Thank all of you.
I'm really, very, very happy with the turnout and with the success of this meeting tonight. A lot of good information you shared with us, a lot of great questions from those of you in the audience. So thank you very, very much for coming out. As I said, we do have the t-shirts available that I hope you will think about purchasing, and I hope we'll see you on August 20th at our next program at the library.
Funding for Simsbury Community Television is provided in part by contributions from viewers like you. Thank you.